Good morning, everyone, and thanks for joining us for the breast cancer Q&A webinar. The topic for today is invasive lobular carcinoma. I'm joined by Sharon Merritt, who is a patient advocate. You want to introduce yourself, Sharon?
Yeah, I'm a patient advocate. I work with a lot of ladies that call me and ask me advice. I don't ever tell them anything medical. I just tell them knowledge is power, attitude is everything. And then I suggest they do their own research so they know what to talk when they talk to the doctors, they can talk intelligently.
Thank you. Thank you. Well, part of the process of sort of doing your research is submitting questions and having them answered. And so we thank you for assembling some questions that were submitted by people through social media who had questions about invasive lobular carcinoma. I'm a breast cancer surgeon. I treat this condition, and I'll do my best to respond to the questions that have been submitted. Today will last 1 hour. We're actually meeting in the conference hall at a convention, so it's not as quiet as it usually is in the background, but at least in the cleanup of the video that we produce after this, I'll try to eliminate some of the background noise so that hopefully will come through more clearly. Let's
Okay,
start with the first question.
what is invasive lobular carcinoma?
Okay, so the question is, what is invasive lobular carcinoma, or what is invasive lobular cancer? Invasive lobular cancer is one of the common types of breast cancer. As you know, you've probably heard about invasive ductal cancer. That's the most common type. And that's about 80% of the cancers that we treat today. Invasive lobular cancers constitute about 10 to 15% of the cancers that we treat. So it's the second most common breast cancer. It's called lobular, and the other type is called ductal, but they really arise from the same part of the breast. They arrive from the very ends of the milk duct. We call that the terminal ductal lobular unit, from the very ends of the milk duct. But they grow differently. And the main distinction is that invasive ductal cancers want to form ducts because that's their natural tendency. So in order to form ducts, even this cancer cells, when they try to form ducts, they try to attach one to the next, kind of like beads in a chain, one holding on to the next to form a round tube. And they can do that because these cancer cells, ductal cancer cells, have proteins like glue that allow them to stick together. And that's why they tend to form tubes. Lobular cancers lack the protein, and as they form and grow in a different way, since they don't have those proteins, the cells don't bind together. They kind of trail like one next to the other, like you're sitting next to me. Sometimes they're stragglers, like one sitting over there and one sitting over there, because they don't bind together. And the fact that they don't bind together often makes it hard to find.
And probably harder to treat.
Harder to treat in some ways, but mostly harder to find because if you kind of imagine like a mammogram being like a satellite trying to find something on Earth, which is basically we're looking at using X-rays to try to find something in the breast. It's easier to find things if they're crowded together.
Right.
But if they're sort of scattered about, it's kind of hard to find, a developing cancer if the cells are scattered about or if they're spread out over a bigger distance. So the fact that ductal cancers tend to bunch up make them easier to find on mammograms, ultrasound, MRI, and by exam also.
What is lobular carcinoma in situ and how does it differ? Oh, I'm sorry, I missed that. Our invasive lobular carcinoma usually estrogen receptor positive and HER2 negative.
Well, I think actually mixed an important one. There was a question there.
What you just...
No, it was a different question.
Oh, I'm sorry. What is lobular carcinoma in situ and how does it differ from invasive lobular carcinoma? Okay.
Yes. So lobular carcinoma in situ is called LCIS. Just like there's ductal carcinoma in situ, DCIS, there's something called LCIS. Now, what's important about LCIS is that up until about 10 years ago, sorry about the background noise. The thing about LCIS is that up until about 10 years ago, LCIS was considered a cancer. It was considered cancer like ductal carcinoma is considered cancer. But it actually has been downgraded to what's considered to be a benign condition that's a high risk factor for breast cancer. And in some cases, it might evolve into cancer, but it's not considered a cancer. So it doesn't have to be treated like a cancer. But it's important to know because many women are diagnosed with LCS based upon biopsies that were done. And if they're diagnosed with the diagnosis of LCIS, it means that they're at high risk, have a higher risk of developing breast cancer, and that they should be screened more closely. And that higher risk also means that they have a higher risk of forming invasive lobular carcinoma, even though most of the cancers that form in these patients are still ductal cancers. It's just more than a 10 to 15% chance, like the average population. It's more like a 20 to 40% chance of having a lobular type of cancer.
So it's kind of like DCIS in a way.
Yes, it's just that DCS is considered to be a pre-invasive cancer. Like if it's left in place, it will likely develop into invasive. There's a high chance it would develop into invasive cancer. And we treat it like a cancer. We do lumpectomy, we give radiation, we give medication. In the case of LCIS, we may do surgery to confirm the diagnosis, but it does not require medication, although you can give it to reduce the risk. It does not require radiation. Some people with LCS might opt to have prophylactic surgery to prevent breast cancer from forming, but it's not a cancer that we're treating. It's a kind of benign condition that we're treating for prevention.
So the LCIS is less likely to become cancer than the DCIS.
Much less likely. And in fact, if I were to do surgery and say if a patient has DCS, if I were to do surgery, it's really important for me to cut out the DCS and have a surrounding margin of normal tissue. That would be considered a successful procedure. But for LCIS, it's not necessary to have clear margins. When we remove it, we're just removing it to sample more tissue to be confident that there isn't associated invasive cancer there, but we don't have to cut it until we get clear margins.
Okay. Are invasive lobular carcinoma usually estrogen receptor positive and HER2 receptor negative?
Yeah, so one of the main differences between ductal cancers and lobular cancers, invasive ductal and invasive lobular cancers, that invasive lobular cancers are almost always estrogen receptor positive. Not always, but almost always estrogen receptor positive. Whereas you know, many ductal cancers are not estrogen receptor positive. Maybe 25% are not estrogen receptor positive. The same thing is true for HER2 new, that invasive lobular cancers are rarely HER2 new positive. Whereas for ductal cancers, about 20% of them are HER2 new positives. In my practice, in my career practicing, breast surgery, I have seen fewer than 5 triple negative lobular cancers and fewer than 5 HER2 positive lobular cancer. They're that uncommon. Over 20 years, I don't even see one a year. So the good thing about that is that these cancers, since they tend to be hormone receptor positive, and they're strongly hormone receptor positive, they are very responsive to anti-estrogen therapy, unlike many ductal cancers, which are not.
What is the pleomorphic lobular carcinoma?
Yeah, the word there is, what is pleomorphic lobular
Okay.
carcinoma? So pleomorphic means different shapes. I think I was just backtrack one moment. One reason why the lobulars are also hard to find is that the cells tend to be small and round, and they kind of blend in the background very well. They tend to be fairly uniform shape, almost look like lymphocytes. So you might, under a microscope, they might look like inflammatory cells, and you might initially not think, if it's sitting by itself, that it's actual cancer. But pleomorphic means different in shapes. And so this particular subtype tend to have cells that vary in size, but they also vary in their receptor expression. It's this type that's more likely to be HER2 positive, and this type that's more likely to be triple negative.
Does ILC have the same prognosis as invasive ductal carcinoma?
So the good news is that pound for pound, if you will, or hopefully gram per gram, invasive lobular cancers have a better prognosis than ductal cancers. The reason, in retrospect, will be kind of obvious. The way that we measure cancers is to measure from one edge to the next, to the outer, to inner, out, the left edge to the right edge. And so if you have a 1 centimeter ductal cancer, you likely have ductal cancer cells extending from one edge complete to the other edge, stuck together, piled on top of one another. That's what we would grade as a 1 centimeter cancer. But you can get a 1 centimeter invasive lobular cancer by having one cell here and then a space, one cell in the space, one cell in the space until you get to 1 centimeter. So they tend to be less dense, inch per inch, or centimeter per centimeter. The challenge is more of a surgical and a treatment one, that even though there might only be 10 cells, they can be spread over several centimeters. And we have to remove the whole area. So, but behaviorally, the cancers are less dense. So there are less cells to multiply. The other factor is that they tend to be strongly estrogen positive. And so cancers that are estrogen positive tend to do better than those that are not. They're rarely triple negative, so they do better, but because they're almost never triple negative, they're almost never HER2 positive. And then the last part is that one of the ways that we grade cancers is to look at how many cancer cells under the microscope show that they're multiplying. We call that the mitotic rate. It's part of the determining grade. Invasive lobular cancers tend to have a very low mitotic rate. They tend not to multiply very much or very fast. And so that makes them this list of things that I just described collectively make invasive lobular cancers on average less aggressive than ductal cancers.
Why is ILC harder to detect than IDC?
Well, we reference that to some degree, but I'll give you a little bit more detail. So the cells tend not to adhere to one another. They tend to be more diffuse. And so they're less likely to form a mass on the mammogram. They're less likely to form a mass on exam. And they're less likely to be seen on MRI.
Because they're probably smaller.
The cells are smaller and they're more diffuse. Another reason is that there is this natural tendency when cancer started to grow for the body to try to form an immune response to it. And often there's some scarring that happens at the tumor that makes, just kind of adds to the density of the tissue and makes the mass stand out better on a mammogram or ultrasound. Ductal cancers. Lobular cancers tend not to induce such a scar reaction. And so they don't have the added benefit of having, collagen to show it, help it stand out on the mammogram or MRI. So that's the main reason why. Many people with lobular cancers have normal mammograms, but they might have a big mass because it can blend in so well. It makes it harder to see on a mammogram, even if the mammograms aren't dense.
What imaging studies are best for detecting ILC?
Well, the question is, there are two answers. Which imaging study is great for detecting ILC? Nothing's great. In terms of best, MRI would be the best. But every imaging study has pros and cons, has strengths and weaknesses. And so, we always start with a mammogram because about 50 to 60% of these we detected pretty reliably on the mammogram. Other people will have a mammogram that's not so clear, but they'll do an ultrasound, and the ultrasound will show something, some defect, some mass that the mammogram might not show clearly. What we get with MRI is that on mammogram and ultrasound, it might look this big, but when you do the MRI, it'll look that big because the MRI will show more than the other studies. Yeah, it'll show more of the disease extent than mammogram or ultrasound. So really, it's best to do all three studies because mammogram often underdiagnoses it or misses it completely. Ultrasound can see it in many cases, but will underestimate the size. And MRI is the best thing at estimating the size, but it too isn't perfect at that.
What about a PET scan?
A PET scan is not really done. There's a thing called a dedicated dedicated breast PET, which is PET scan that looks only at the breast. Frankly, I'm not familiar with how it performs for detecting invasive lobular carcinoma, but a standard PET is not really useful for staging breast cancer, for estimating the size of breast cancer. Even ductal cancer is not well measured in the breast. It's good for other body parts. but PET scan is not really used to estimate breast tumor size. And in fact, I would generally disregard what the PET scan says about the breast.
So it's more for changes than it is for actually seeing something initially.
What is that?
The PET scan, like it's more useful to see if things got worse or better.
Well, a PET scan is most appropriately thought of as a functional study. It's looking at behavior.
Right.
And so it's looking at the consumption of glucose. So although it does kind of give you a sense of size, like there's glucose consumption over this area versus this area, the main thing we're trying to see is there an area that stands out more than others because it has more glucose consumption? And then we would compare that to what the CT shows, and the CT says, hey, at this site, there's a round mass or a square mass or a star-like mass, and therefore this mass is hyperactive and likely abnormal because it's consuming glucose more than others. But CAT scan isn't great for defining breast anatomy. So that's why we don't use PET and CAT scan in general to measure breast tumors in the breasts. We use mammogram, ultrasound, and MRI for that purpose.
Why is IDC harder to detect than, or LDC hard? Am I going backwards?
I don't know.
We did the imaging studies. How is ILC staged?
So staging. Well, ILC is staged like IDC or invasive ductal carcinoma. Staging is based upon three principles: measuring the tumor size, measuring the nodal status, and measuring whether or not assessing whether or not there's distant disease, like spread beyond the breast or lymph node area. Nodal size is pretty straightforward. We're trying to determine if the node is positive or negative, if there's cancer inside the node or not. Tumor size is a little bit misleading, as I described, because the way that we measure
Right.
cancers, but that's all we have. And so if there are 10 cells and they span 10 centimeters, we would measure it as a 10 centimeter invasive lobular carcinoma.
Wow.
Because that's the only way that we have to measure this. And so it's not a perfect way.
Okay, how is invasive lobular carcinoma treated surgically?
Well, fortunately, most people can, with invasive lobular carcinoma, have the same options that someone with an invasive ductal carcinoma has, which is to say that if it is small enough, it can be treated with a lumpectomy. Can
it be frozen?
And if it's small enough, it can be frozen. In both scenarios, the caveat, the but, is that there's a greater chance of underestimating the size. So that people who have lumpectomy have a higher chance of having a second operation to get clear margins. Patients that have cryoablation have a higher chance of needing the second cryoablation procedure because of something that appears later that wasn't apparent initially. One way that I try to, and I certainly treat patients with invasive lobular carcinoma with cryoablation, but to kind of acknowledge the fact that we often underestimate the size, I usually recommend that we treat a much larger volume, not just a 5 millimeter or 1 centimeter margin, but aim for a 2 centimeter margin to have a wider margin of error around the tumor, since, as I said, we know often that imaging underestimates the size of invasive lobular carcinoma. I would just add that because of the biggest challenge with invasive lobular carcinoma, detection is often delayed because they're hard to see. They tend to be detected when they're larger in size, when they've spread out over bigger areas. So there's less odds of having a successful lumpectomy because the tumors tend to be bigger because they just have more time to grow before detected. And so there's a greater chance that patients will require a mastectomy because the size is often bigger than you can treat with a lumpectomy.
How effective is preoperative and postoperative chemotherapy in treating ILC?
Yeah, so the question is, what is the effectiveness of chemotherapy before surgery to shrink a
Versus
tumor
after, yeah.
versus giving chemotherapy after? And so the answer largely is determined by the fact that these tumors tend to be lower grade. They tend to have a lower multiplication rate or mitotic rate. And those two factors tend to make them less sensitive to chemotherapy. Now, if someone has advanced stage invasive lobular carcinoma, we will offer them chemotherapy to get whatever kind of benefit we can out of the chemotherapy. But most of the benefit of therapy comes from giving anti-estrogen therapy. Now, because preoperative or postoperative chemotherapy don't really work so great, it's not likely to shrink the tumor. We sometimes give chemotherapy prior to surgery with the goal of shrinking the tumor down to a smaller size so we can do a lot smaller surgery.
Plus you find out if it reacts to that particular chemo.
You also determine that as well. But as you know, if they don't respond very well, they don't shrink very much. And furthermore, if you have a cluster here and a cluster there, both clusters might shrink, but they don't shorten the distance between them. So you end up having to remove the same amount of tissue. So we don't usually recommend preoperative chemotherapy or even preoperative anti-estrogen therapy to shrink these tumors.
How does the prognosis of ILC compare to invasive carcinoma?
We talked about
think
that.
about
ILC is usually better.
What is the role of radiation in treating ILC?
Well, radiation is used as a standard procedure for patients that are treated with breast conservation. So most people, certainly under the age of 70, if they require a lumpectomy, they would be offered radiotherapy as a way of reducing the risk of recurrence within the breast. So that's pretty standard. We call that breast conserving therapy, lumpectomy combined with radiotherapy. For patients with no positive disease, they're generally advised to have radiotherapy that includes the lymph node area. And of course, if someone has been treated with mastectomy but has more advanced disease like a positive margin or a positive node or a large tumor size, they too may be advised to have, would likely be advised to have radiotherapy. Radiotherapy works for invasive lobular carcinoma. And so, based on stage, it's recommended.
What is the role of cryoablation in treating ILC?
Well, cryoablation is, most of the studies that have looked at cryoablation have excluded patients that were diagnosed with invasive lobular carcinoma for the reason that we mentioned, that they're just kind of harder to measure. However, I've certainly encountered a number of patients that were unwilling to undergo surgery. And rather than letting the tumor grow and potentially spread, it made sense to give her the best odds of a successful result by performing cryoablation with a wider margin, with the caveat that they'll need to have ongoing monitoring, with MRI included, to see if over time, 6 to 12 months, if something new emerges. If something does emerge, then that additional area can be targeted. Of course, I would still recommend radiotherapy based upon the size. These are very estrogen dependent, so I would recommend anti-estrogen therapy because that's part of the ability the goal of controlling the growth. But it's doable. Just we are selective about who's offered this treatment if they have invasive lobular carcinoma.
Does ILC spread to the same places as IDC?
So that's kind of an interesting phenomenon. So breast cancers, whether it's IDC, ILC, they have a tendency to spread. If they spread, the places they're more likely to go would be the bone, the lung, and the liver. Ductal cancers have a higher chance of going to the brain as well, especially some types. And that's usually the profile you see for ductal. It's also the profile you see for lobular, but lobulars have some really strange behaviors. They tend to like to go to the abdomen. So it may be a metastasis to the stomach. They may go to the small intestine. They like to metastasize to the lining of the abdominal wall. We call it the peritoneum. They like kind of surfaces. And the cells also have a higher chance of going to the lining of the lung, not the lung tissue itself, the part that exchanges oxygen, but the wall around it. We call that the pleura. And so it's this unique pattern that you have to kind of look out for this, especially if you're having some weird abdominal symptoms or lung symptoms. and you've had a diagnosis of invasive lobular carcinoma, you have to think about that as a possibility. There's also one other phenomenon that I've seen for patients. One of the phenomena that I've seen for patients with lobular cancers, which is that they tend to like to go to the skin. As I said, they like surfaces. So whenever I see a patient that's being followed up in the office, I always do a little extra, give extra focus to the skin, because if there's like a red pimple on the skin that's new, that's often how they will present it, as a red sort of raised, you know, maybe 2 millimeter or more raised area that you might think is just a zit. If you've had a diagnosis of invasive lobular carcinoma and you see that developing on your breast, you should have it checked out, maybe have a punch biopsy done, because that's one way that I've seen recurrences happen. So it's like a metastasis to the skin that happens
Do they
in the
ever,
breast area.
do they ever, if you have a lot of that, work backwards and go from the skin and check on the lobule?
Well, there are people that have not had a diagnosis of breast cancer because, again, they may have had a mammogram that didn't see it. They might have had a, ultrasound. The ultrasound wasn't done perhaps because they just were getting screened, but they presented with skin redness, like a rash, not like whole breast redness, like inflammatory breast cancer, but a patchy area of skin that you might have thought was eczema. And that's something to think about, because it's not it's an uncommon presentation, but it is a known presentation of lobular cancer, where the skin manifestation was the first thing that led to a more thorough workup that revealed an underlying invasive lobular carcinoma.
Does ILC spread to the same places as IDC?
We just covered that
Yeah.
one.
How
Yes.
common is ILC bilateral?
So bilateral meaning developing
both
in both
sides.
breasts, either at the same time or at different time points. It's not, I was just saying, it's much more common than it is to have ductal cancer presenting as bilateral cancer. The first principle is that invasive ductal carcinomas are bilateral in about 5% of patients. If you think of the general population, about 5% of patients will have breast cancer in both breasts, either occurring at the same time or at a different time period. However, in the case of lobular cancers, there's about 25% of patients who will have breast cancer in both breasts, not necessarily at the same time, but at one interval and then at another time point in their life in the other breast. We call that bilateral breast cancer. It's called metaconous, meaning that it's not happening at the same time, as opposed to synchronous, which means that it's happening at the same time. But it's something to think about. So one of the risk factors for having bilateral invasive lobular carcinoma is having lobular carcinoma in situ, because LCIS is usually bilateral. And so the fact that it's present in both breasts does increase the probability of there being cancer in both breasts, as well as invasive lobular carcinoma in both breasts. So it's something to think about. Now, I see the question that comes up next, which is an important question because it relates to this question, which is that there is a genetic condition that increases the risk of bilateral invasive lobular carcinoma. And it's a mutation of a gene called CDH1. And so if someone has a diagnosis of bilateral invasive lobular carcinoma, especially if they're younger in age, they should undergo genetic testing with this particular mutation in mind. Now, generally, we recommend genetic testing for people. I mean, the guidelines have generally recommended based on age or family history. There's some of us that believe that we should test everyone, because there are a lot of people that don't have a family history, or don't know their family history, that may be carriers of an important mutation, about 10% of people. And so there are 11 recognized mutations that are commonly associated with breast cancer, either a high risk, like 80%, like BRCA1, lifetime risk, or more moderate risk mutations like a CHEK2, which is maybe like 40% lifetime risk. But CDH is one of those, and it has a lifetime risk of breast cancer of about 60%. And the risk, the cancer that's associated with it is invasive lobular cancer. So whether you're considering testing, because of your age or because of your family history, or just because doctors
Because
like me recommend you have a cancer diagnosis, therefore you should have genetic testing. It's particularly important to think about CDH1 if you have invasive lobular carcinoma, especially bilateral. Um, there's one other thing to know about it, which is that CDH1 mutation is associated with two cancers. It's associated with invasive lobular cancer, and again, bilateral in early age is the key, but it's also associated with gastric cancer. It's associated with a particular kind of gastric cancer called diffuse gastric cancer, which almost, I mean, the incidence of this kind of cancer is almost zero, except for mutation carriers. So and the reason why that's important is if you have a family history of gastric cancer, one should consider genetic testing because that might indicate you have a high risk of having this mutation and possibly invasive lobular carcinoma. If you have a family history of invasive lobular carcinoma, you may want to consider genetic testing because it might indicate you're at risk of this particular gastric cancer. So it's the two of those together, and one might precede the other. So you might have invasive lobular now and develop gastric later. You might have gastric now and develop invasive lobular later. So it's important to know if these cancers are happening in your family and to get genetic testing if you have a diagnosis of breast cancer.
Okay.
Yes.
that was those questions. You want to do any of these?
Sure. We have some additional questions.
A new non-osteoporosis causing treatment to look out for in hormones and ILC.
Repeat the question.
Says any new non-osteoporosis causing treatments to look out for in hormone and ILC.
Okay, so I'm interpreting it as, are there any new non-osteoporosis causing treatments that are available for hormone receptor positive ILC? So, we've established that ILC tends to be strongly ER positive. So the systemic therapy that we would give that person would be an estrogen targeted therapy, like tamoxifen or like an aromatase inhibitor. Tamoxifen is predominantly given to premenopausal women, but it's also available to postmenopausal women, and it is not osteoporosis formally. So if there's a concern about osteoporosis, especially and you want to avoid aromatase inhibitors, tamoxifen is an available solution. The other category, as I said, are aromatase inhibitors like Arimidex, like letrozole, like exemestane. These are drugs that prevent your body from making estrogen by targeting the enzyme. And one of the side effects of the entire class of aromatase inhibitors is that it can cause some bone loss over time. So I am not personally aware of an aromatase inhibitor that doesn't have that as a risk. And so it's something to screen for. There are treatments to reduce the progression that your doctor can give you along with aromatase inhibitor. But if the concern is great, like if you already have osteoporosis or osteopenia that's progressing to osteoporosis, or a fracture that you're concerned about, it's reasonable to discuss the pros and cons of tamoxifen, because tamoxifen is bone protecting, but it tends not to be used in postmenopausal women because it has some additional risks, which we would avoid if we could. And at least head to head is not quite as good for postmenopausal women, which I think relates to another question.
The value otherwise of new liquid biopsies, existing blood tests, etc. for ILC, specifically that patients can start researching and requesting.
Yeah, I'll have to defer this to medical oncologists. I don't do liquid biopsies. I actually am frankly not up to date on liquid biopsies. And there is, real questions about how meaningful it is for breast cancer, although it is more meaningful for some other types of cancer. So I say for this kind of question, they should definitely discuss it with their medical oncologist to see if they think it's reasonable for them to take.
I've seen some new ones coming out recently.
Yeah, I just don't know what to advise about them. Sorry.
What are your thoughts on the Rebecca Glazer testosterone with estrogen blocking protocol for lobula?
So I looked that up when I read this, when I got this question, when you shared the questions with me previously. The question is, what is the benefit or efficacy or effectiveness of combining testosterone with an aromatase inhibitor as a way of providing hormone replacement therapy for someone who who wants to avoid estrogen, especially if you have a diagnosis of breast cancer. The concern is, you can't take estrogen if your cancer was ER positive because that would increase your risk of recurrence. Does taking tamoxifen combined with anastrozole provide a way of safely managing your menopause symptoms, hot flashes, and night sweats, for example, while not increasing your risk of developing breast cancer? And the one study that I did take a look at that discussed this did show that women that were on tamoxifen and anastrozole did not have an increased risk of breast cancer. So it seems to be a safer way of managing menopause symptoms without increasing the risk of breast cancer. Now, in that paper, I did not see whether or not, testosterone was protective of the bone. It did not address that question. So I don't know if it's protective in that way. This particular article did not describe how effective it was for managing hot flashes and night sweats, but it did at least focus on the question of the safety of this combination in terms of its impact on breast cancer risk. And it did not see an increased risk of breast cancer amongst people with this regimen. So it might be worth a try to see if it can control, if you're having severe side effects, you're willing to take anastrozole and testosterone, it might be an effective way of managing, postmenopausal symptoms.
I find it interesting that lobula shows up in both ER positive and HER2 positive. I'm not certain about TNBC.
Right. I think we addressed this one earlier,
Yeah.
but I'll touch upon the key points that lobular cancers tend to be strongly ER positive, like 90% or higher. They tend to be strongly PR positive, generally about 60 to 70% on average, and they are rarely HER2 positives. However, there is this pleomorphic lobular subtype that can be triple negative and can also be HER2 positive. So although they're uncommon, they can happen, and they need to be treated based upon their biomarker profile. So if they're HER2 positive, they need anti-HER2 therapy.
That's basically what they're asking, because they're saying, I know that an ER positive, HER2 negative lobular chemo is not recommended because it's been shown ineffective. But what about HER2 positive? Does it give these women more reason to ask for only Herceptin and Perjeta along with the estrogen blocking?
Good question. So HER2 positive breast cancers, whether it's ductal type or the invasive lobular type, they all benefit from anti-HER2 therapy. And anti-HER2 therapy is best given in combination with chemotherapy, because chemotherapy makes the cells more prone to respond to the anti-HER2 therapy. Although anti-HER2 therapy standalone has some benefit, the benefit is probably six times greater when you combine it with chemotherapy. So, it's better than not taking anti-HER2 therapy, but it's not as good as taking it. And so even though the cells, the chemotherapy as a standalone treatment doesn't work all that great for
HER2 positive.
For chemotherapy as a standalone doesn't work all that great for invasive lobulars.
Okay.
The HER2 positives that are HER2 positives tend to be more beneficial, because in this particular instance, even though I gave you those rules about the behavior of invasive lobular carcinomas, the pleomorphic type tends to be the more aggressive type, tends to multiply faster, tends to have a higher mitotic rate, and it goes along with them being triple negative HER2 positive. So they're more likely to be responsive. That rule about chemotherapy not working so well does not apply to the pleomorphic types.
Okay. I'm BRCA1 gene with HER2 positive, just got my cryoablation done, and I want to ask, what is the recurrence rate for my type, excuse me, my type of cancer and blood tests we need to do in order to control the disease?
So the story here is that she has a BRCA1 gene mutation. She's BRCA positive, and she has a HER2 positive breast cancer treated with cryoablation. So it's a little complicated situation, but there I'll just break it into pieces and then hopefully combine them. BRCA1 positive, obviously, there's an elevated lifetime risk of having breast cancer when someone has a BRCA mutation, and an elevated risk of having a recurrence as well. But as someone ages, the remaining lifetime risk is less. I mean, your lifetime risk when you're 30 is not the same as your lifetime risk when you're 60. And in fact, many people who have a BRCA mutation over the age of 60 can be treated with breast conservation because their residual lifetime risk of having a recurrence is
A lot less.
a lot less than it was when they were years earlier, when they were years younger. So, but it is there. But there have been a number of studies that have looked at breast conservation and BRCA mutation carriers, and they compared it to breast conservation. Breast conservation meaning lumpectomy and radiotherapy. They compare that to breast conservation in people with non-mutation related breast cancers. And the studies have generally shown that the recurrence risk is higher in the mutation carriers. There's some that showed it's about the same, others that have shown that it's about 50% higher, 50 to 60% higher. So in one case, it might be 10-year risk in 10 years, and the other case would be 15 to 20% risk. And so, it's a matter of informed consent. You tell the patient the comparative risk, and they have the freedom to choose. The stipulation here is that all of these studies were reported in patients that had breast conservation therapy, meaning they had lumpectomy and radiotherapy. And if radiotherapy had been admitted in the BRCA carriers, their risk of recurrence might have been a lot higher. Which takes me to cryoablation. So cryoablation is being done here as a substitute for lumpectomy, I assume, and I'm assuming the margins are clear. But in the absence of radiotherapy, we don't really have any data to say that her risk of recurrence, well, we don't have any data to say what that risk of recurrence would be, but it would likely be, higher than what one would see than the numbers I've recorded, higher than 10 to 20% over a 10-year period, because the radiotherapy plays an important role in reducing the risk of recurrence in high-risk patients like a BRCA positive patient. So, certainly she has a freedom to decline radiotherapy, but if she is, then if it's here, it's it's also HER2 positive.
Yeah.
Okay, so you have to sort of think about
Herceptin,
Perjeta, and chemotherapy, ideally, because if you're not if you're in a high risk situation with a BRCA mutation and you have a cancer treated without radiotherapy, then your risk of in the breast, your risk of recurrence in the breast is higher. Your risk of recurrence in the node is higher. Your risk of recurrence distantly is higher. And so you might need to rely more heavily on the systemic therapy as a way of reducing the risk of recurrence in all places, breast, lymph nodes, and distantly.
Recommendation for follow-up screening for lobular breast cancer is MRI or contrast enhanced mammogram, generally every 6 months. I can't handle all the iodine in the contrast enhanced mammogram, and my insurance won't pay for the MRI every 6 months. Is there any alternative screening method that will detect the lobula? Research is showing that it is often missed on mammograms without contrast.
Right. So, there actually is such a thing called a contrast enhanced mammogram. It's not widely available and it does not use gadolinium. And so if I'll just put out there, if gadolinium is a problem for you and you have contrast enhanced mammography available to you, then it's better than mammography alone. And so you might want to look into that. But in general, for patients with a diagnosis of invasive lobular carcinoma, we rely upon mammogram and ultrasound as the primary studies for follow-up. And we do those studies generally yearly after their diagnosis. And we tend to also lean heavily on MRI as a supplemental test. Whether or not mammogram and ultrasound alone is an effective solution depends in part on how the cancer originally presented. Many people have their cancers detected by mammogram and ultrasound, even lobular cancers. And so if it was effective at detecting the first cancer, and that would be about 60% of people, then it's reasonable to use mammography and ultrasound to do the follow-up imaging yearly. However, if it was missed by the mammogram, or if the mammogram greatly underestimated the size, then in that case, it makes more sense to lean on the MRI as a way of using it as a way of facilitating early detection, since your tumor, the cancer basically told you how its tendency for how it would present. So you can basically customize the screening protocol after the initial treatment based upon the initial presentation. Of course, we would recommend yearly MRIs in this case, but I mean in general, but in this case, if she has some issues with it, then you could space it out further, do mammogram ultrasound and do MRI every other year, every third year as a way of screening. Or if you have contrast enhanced mammography, you could use that in combination with ultrasound. It's important to know that the pattern of recurrence of lobular cancers tend to be different than ductal cancers. As you know, and you've heard before, the more aggressive, the faster the growing cancer, the more likely it is to recur early, meaning that, ductal cancers or higher grade, like pleomorphic lobular cancers, have a peak recurrence in like the third year.
Like her too.
Yes, in third year. And the more aggressive ones, maybe like 2 years, but then it sort of drops off to a lower level after that, and it doesn't really peak again. But for lobulars, it tends to be a little bit more of a gradual slope. So they don't peak. There's a little bit of a peak early, but it kind of continues to go up over time because everything's happened slower.
So you don't even know, you can't say after 10 years, it's not going to come back.
Yeah, you can.
It's not like the other ones that you can say after
feel-
so many years, it probably is not coming back.
Exactly. Like in the case of the higher grade cancers, if you develop a new cancer, say 5 or 10 years later, we would generally consider that there's a higher probability that that would be kind of a new primary, like a new thing that happened on its own, based upon more mutations or whatever. But a late presenting lobular cancer is more likely to be residual disease, just something that was there that just continued to progress or that continued to grow. Yeah, because it was just undetectable, and so at least initially. So you tend to have a longer period of time of observation, say not the first 5 years, but look at the first 10 years to have the same level of confidence that recurrences won't happen. And there's a fairly good, history of these recurring about 15 years, even out as long as 15 years after the initial diagnosis, where, it's just, but, that's, if you have a disease that's fairly well controlled with anti-estrogen therapy, a 15-year time course is a pretty good run, especially, if it recurs, you just treat it again and put one anti-estrogen therapy and hopefully go another 15 years. So I think there's a reason. The other thing is, generally, historically, we've treated patients with ER-positive tumors with 5 years of anti-estrogen therapy. But, in some cases, we use a longer course, but it doesn't mean if you have a lobular and you have a recurrence, you can go on anti-estrogen therapy again and continue a longer course for longer benefit.
I have a question I get asked all the time. It's relates. The women are asking, if you find out you have really dense breast, why do they make you have the mammogram? Why don't you just go straight to the ultrasound since you need the ultrasound anyways?
Because you need both. Well, so here's something that didn't come up. So one of the ways that ductal cancers and DCS
You mean
commonly,
ocular and DCS?
no, I'm saying
Oh,
ductal,
ductal, oh, okay.
ductal cancers
Okay.
and DCES, they don't have a higher chance of having, so that's kind of a strangely worded. Let me restate the question. For ductal cancers and for DCES, there is a higher chance that they will have calcifications develop in association with the cancer. And calcifications can only be seen reliably on the mammogram. So if the goal is to find DCES or invasive cancer as early as possible, and calcifications is the earliest thing that can be found, it makes sense to use a mammogram as part of the evaluation because it might give you a better sense of the extent of the disease or find some things that don't show up in the ultrasound because calcifications can't be easily found on ultrasound. They can be seen, but they're hard to see. And they can and it's really the mammogram that shows us calcifications, which is why screening mammography still is an important part of early detection for breast cancer screening. It opens the door to finding DCES more consistently, to finding early stage breast cancer when it's small. It isn't relevant to this discussion. It's notable that lobular cancers tend not to present with calcifications, which is another reason why the diagnosis is often delayed because they don't have these fine calciums that form in association with the cancer to enable it to be detected more readily by the mammogram. The one exception is the pleomorphic lobulars. They may have calcium deposits, but lobulars generally don't have calcium deposits.
So they don't show up on mammograms.
Right. So that's why you can't rely upon the ultrasound alone
Okay.
because, even though the mammogram might not show the mass, it might show calcifications extending beyond the mass. And that tells you you have a bigger problem to treat than just the mass. Or it might show calcifications in another part of the breast that no one was looking at or feeling, and that might affect how you're treated.
What happens when you get to the point where you're having PET scans all the time? Will that show up stuff, or do you still need to go back and do mammograms and all the other stuff?
Well, if your disease is controlled, there are different scenarios for PET scans. You can do, say, stage 1, stage 2, stage 3 disease. PET scans may be done as a way to look for recurrence, like particularly recurrence outside of the breast area and the liver, lung, etc. And so if someone has stage 1, stage 2, stage 3 disease, and they have intact breasts, they should still have routine screening their breasts. And the PET scan may be done selectively as a way of just making sure that they don't have any new disease developing elsewhere. It's slightly different for patients with stage 4 disease. There's at least kind of a practice. I don't know if the right practice, but there's a tendency for the focus to be primarily on the distant disease and not so much on what's happening in the breast anymore. It's kind of like the cat's out of the bag, so they kind of focus on,
Where to go?
where the cat is gone, as opposed to the bag, so to speak. uh, and uh, and so, but if someone has well-controlled systemic disease, I think it's still important to focus on the breast disease. And so you can discuss with your person with stage 4 disease can discuss with their doctor if it makes sense for them to focus on screening the breast, meaning or monitoring the tumor. There are really two thoughts about it. Number one is, screening is primarily done for detection of disease early. If there's already stage 4 disease, what is finding another early cancer in the breast going to do? Therefore, that's why it's not usually recommended in stage 4 disease. But many people with stage 4 disease have not had their cancer in the breast treated, meaning that it's not removed surgically. They don't undergo lumpectomy. They don't undergo mastectomy. They're primarily managed with medications. And sometimes those cancers can grow. Sometimes they can give rise to new metastasis. So I think it's important to know how that tumor is responding and not just rely upon how it feels. Maybe in this case, you do the ultrasound and not do a mammogram, but it should be
mine.
so it makes sense to do some kind of monitoring because it's possible for you to have well-controlled systemic disease, but have a disease in the breast that's not
ready to take off.
and you'd want to manage that in some way to prevent it from becoming a secondary problem. But that's why there's a little bit of uh, chaos or confusion about what's appropriate. If you at least hopefully that helps you understand sort of why maybe that you talk about screening until there's stage 4 disease, and no one talks about screening. It's because
So, but then you end up with lots of PET scans and CTs.
yeah. So the
Very
answer,
often as too.
which is how your question started. I'm sorry if I got off track.
No, that's fine.
So for stage 4 disease, you're primarily looking at what's happening outside of the breast to see if there's further growth or response to the areas that you're targeting, or if new areas show up. The PET scan will also see the breast. It'll also see the lymph node. As we've talked about, the PET scan isn't great for detailing what's going on in the breast. So we just make a note of it, but don't really respond to it. It would show if the lymph nodes are more active or less active. But the main goal of the PET scan in that case is to look at in the liver, lung, bone, and other places where cancer can grow and become, produce illness. And that's the reason for. And so, you work out with a medical oncologist, the frequency of that. Often it's coordinated with changes in the regimen. So if you change your regimen, you want to know how it responds, you do a PET scan before, you do a PET scan after, and then gauge whether or not you stick with that regimen or not, based upon
PET
what
scan.
happens on the PET scan. But it's an important test because, as we described earlier, it's a functional test. It's not just looking for the shapes and sizes of things. It's trying to ask, is it alive? Because you could have a mass, say in the liver, that responds to treatment, but it stays a mass. But if it goes from PET positive, meaning active, to PET negative, meaning not active, that's a really great sign that the tumor is either dead or indolent, not growing. And so you can't necessarily tell that by the change in size, but you might be able to tell that by the change in how much glucose is absorbing, which is what the PET scan is measuring.
But if you had a breast cancer, it would show up on that too, right? As far as the activity, it would.
Yeah,
go
but
for
it's
the- But it wouldn't give you the definition, I mean, all the other part you need.
right. It'll tell you if something's happening there, but with PET scan, although we say PET scan, it's a PET scan, a functional study combined with a CAT scan. And so it's a CAT scan that gives you the size measurements. It's a PET scan that gives you the activity. CAT scans are poor for measuring breast tumors in the breast. So that's why we don't usually rely upon the PET scan to tell us the dimensions of the breast tumor. They'll describe it.
Well, I was looking at it more from the point of view that if somebody made it to stage 4 and they're getting PET scans all the time, that if they don't see any activity in the breast,
That's encouraging.
you don't need to do anything else.
Right.
But the PET scan will show you if there's activity, then you need to go do all the other things to find out the size and whatever.
Yes. There's one little note I would make about it, which is that, activity can mean cancer. It could mean healing. So if you've had surgery of the breast and you've had a PET scan to look for disease elsewhere, the breast will often show up
Oh, yeah,
because it's showing up not because you have residual cancer, but that it's just
but it
healing.
doesn't show up really active, super active, like the
Right.
estrogen
It's a low level activity. But it's, it can cause some anxiety, and so I usually just disregard it because it just causes anxiety, and it usually is just a reflection, not of residual disease, but of healing that is
Right.
happening in a place where surgery recently took place. Well, I think we're arriving at the noon hour. I see some activity in the background. People are starting to show up for their meals.
And it's gonna get really busy.
Yes, but I think we covered all the questions, and
I
I
think so.
really appreciate the opportunity to discuss them with you, and thanks for submitting them. And as we have before, we will have this webinar every other month. There'll be a new topic that we'll put out. If there's something you really want to hear about, communicate with Sharon, and we can center it around that. But again, appreciate your time, Sharon.
I guess one thing I want to say though is that I've learned over time, well, first off, I do everything integrative now because there's good points and bad points on either side. They kind of, when you work them together, they work very well together. Secondly, I think knowledge is power. So the ladies should always research everything so that they know how to dialogue with the doctors and they understand what's going on. And secondly, I think attitude is everything because I think that your attitude can make a huge difference. And the people that go home, get all depressed and lay in bed all day long, I think they tend to not live as long. That's just an observation. It's not anything, I don't have anything to prove it. But I just think, I mean, I'm stage 4 and I'm doing great. And I still have some spots in my lungs, but it's like, it doesn't affect me that much.
Well, thanks for being an example of how someone can deal with this diagnosis and also advocating for those who might not be as empowered to sort of take control of what they can control about their life. Also, sort of facilitating the opportunity for people to do the research and to submit the questions and learn hopefully about breast cancer through this webinar and past webinars, so that they can dialogue with their doctor with a stronger base
Right.
of knowledge.
And I think too, if you don't feel comfortable with, say, your oncologist or your breast surgeon or whatever, get a second opinion, move on. I mean, I had a first breast surgeon that I walked out and I was done with him.
Mhm.
And I fired 2 oncologists. One had weird stuff in my record and the other one just, we didn't get along at all because she didn't approve of a lot of things that I was doing.
And now you're happy with the one you're with?
And Dr. Chap is wonderful. She doesn't tell me not to do anything. She'll tell me, well, we don't know if it does anything, so why spend the money? But since my insurance is paying for it, I don't worry about it. But
But
yeah.
she's willing to kind of
Yeah,
negotiate.
a lot of times I'll go in there after I've had a PET scan and I'll ask her, what do you think? And she'll look at me and she'll go, I want to know what you think first. And then we see if we agree already on it.
Yes, yes.
And then we negotiate
Yeah, yeah,
things.
yeah, okay.
And that's the other good thing. You can, if you have an oncologist, you should try and get them to negotiate with you. Like, I will not take a full dose of things, but then I have a methylation issue, so I don't process things the same way. So I take a lower dose and it works just as good. And I think there's been studies done. In fact, I'm gonna go to a presentation in San Antonio where they're gonna talk about dosing. And I think there was one like 2 years ago that said that sometimes the lower doses, you don't need the maximum dose. Because that was just what they did in the
trial, right? And so that's something to discuss, with your medical oncologist. And
Yeah.
I mean, I think ultimately, a lot of what we do is driven, at least by the principle of patient-centered care. Not all people practice patient-centered care, but it does sort of balance kind of what the guidelines are, what the standard treatment options are, and what the patient is willing to do, tolerate, or accept for herself. And the answer should be somewhere in the middle. It might be closer to one or the other, but it's not, one way or the highway, if you will. It's just gonna be,
Doctors are not gods.
yes.
And I've always thought of medicine as being, they call it the practice of medicine.
Yes,
And that's because it's not an absolute. So
but on that note, it's lunch.
we're gonna go to lunch.
Yes. So we're gonna be cleaning up this video, hopefully eliminating some of the background, hopefully getting rid of some of the background noise as well. And within a couple of days, we hope to have it out to you again on the YouTube channel. And thank you for joining us and all the best.